Hello, and welcome to Hopkins at Home. Thank you for joining us. I am David Bishai, and I'm at home, as many of you are. I'm a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm here with Meike Schleiff, an assistant scientist at the school. And today we'll be talking about our new book, Achieving Health for All, Primary Healthcare in Action. This book just came out on September 15th. And it was written to commemorate the Alma-Ata Declaration 40th anniversary. We are grateful to the support of the World Health Organization and the Alliance for Health Policy and Systems Research. It is a collaborative book, and so we're also thankful to over 30 co-authors who worked with us and who shared their ideas. We are going to try to convey some of their contributions to this important area, an important area that's relevant, especially in a time of COVID-19. So we welcome you to ask any questions that you have by typing them into the chat module of your screen throughout the talk, and we will leave time at the end to answer them. You can find more about this topic at the Johns Hopkins University Press blog post that Sydney should be flashing up for you with links to the ideas from the book and the outline. So I'll turn it over to Meike to lead us off with the outline. Go ahead, Meike.
Thanks, David. Hello, everyone. So glad that you're joining us today. And we do have a lot of ground to cover. As David said, it's been such an honor to work on this project, both with David and also with all of the co-authors that have really sort of shared, their extensive experience working on achieving health for all in a variety of different contexts around the world. So I feel like we've learned so much from looking at this history and also from, working with all of them and finding out, what they're doing now and what they're envisioning for the future, which is where we want to get to by the end of this talk as well and what we all can do. So we're going to start with sort of where this concept of primary healthcare came from and what some of the principles have been that have sort of stood the test of time. And then we have a set of myths related to primary healthcare that we will debunk using the contents from the book and our reflections as well. And then we want to close by talking about the relevance of primary healthcare for the current status with COVID-19 and also looking ahead towards the Sustainable Development Goals and what we all can do to sort of further this mission of achieving health for all through primary healthcare. So let's start with the origins of primary healthcare. So this is a photograph of a conference, a global conference that took place in Alma-Ata, Kazakhstan in 1978. And this conference was really the first time that globally countries came together and along with major development partners at the time. So of course, the World Health Organization, also UNICEF and the Rockefeller Foundation and many others, and said, what should we be thinking about going forward? What should our goals be? And what can we learn from the work of sort of international development and efforts earlier in the century to work within then many colonialized countries, thinking about how to eradicate malaria and setting up mission hospitals and a lot of the efforts that had been going on, and sort of a chance to pause and reflect and see what's working and what isn't, and what should our vision be going forward. Next slide. So leading up to the conference in the mid-1970s, actually 2 books were put together. This is the more well-known one called Health by the People, and there was a second set of case studies as well. And the effort behind both of these publications was to look at case examples of how different programs working in different contexts around the world at that time had been effective in achieving progress in health outcomes, but also looking kind of at the beginnings of thinking about health systems and how to really move communities forward in terms of their own development. And so you can see here, there's a range of different contexts represented from all around the world, including some projects like the Debunked project that still exists today, and then some earlier efforts in a number of key countries that have since also gone on to do a lot of exemplary work around primary healthcare. So these case studies were sort of the foundation for what do we think we can achieve across different contexts, what are the commonalities, and where should we be setting our sights going forward. Next slide. So the declaration that came out of the Alma-Ata conference in 1978 really focused on, how do we address inequalities, how do we improve health status, especially in collaboration with communities, and how do we ensure that we're, incorporating sort of political, social, and economic context around health in order to make that happen. Next slide. So the conference itself in 1978 had some really interesting additional contextual factors that could have certainly derailed it at a number of points in time. The history of efforts beforehand, as I mentioned already, efforts to eradicate malaria hadn't really worked. There was also some dissatisfaction with sort of how well mission hospitals were able to really improve the health of entire populations. And then there was this tension between the Soviet Union and Western countries, with the Soviet Union really trying to promote some of its ideas about how to improve health. And so the World Health Organization, under the leadership of Dr. Halfdan Mahler, who was the Director General at the time, were able to sort of navigate through a number of those and ended up hosting the conference in Alma-Ata, Kazakhstan, partly because that country had the facilities in order to be able to host a large conference like this. And at the same time, sort of a brokering of all the different factors that needed to be considered, and saying, okay, we can go there and see what's happening in the Soviet Union, and we're also going to talk about what we need to do globally. So the declaration for the conference was actually drafted by several key people working at the World Health Organization, and also several other public health professionals from the US and Europe, including Carl Taylor, who was the founding director or head of the International Health Department here at Johns Hopkins, and also Ken Newell, who was based in the UK, and then a gentleman named Joe Cohen, who was hired by the World Health Organization not long before the conference took place, and who ended up having a pretty substantial role in sort of the final drafting and evolution of the declaration. So next slide. So the conference and the declaration that came out of this conference in 1978 had a couple of key achievements. The first one was putting together a comprehensive definition of what primary healthcare is, which we will see on the next slide in a moment, and also really trying to put to paper, this sort of philosophy of this isn't just, a thing to do or a certain set of indicators to achieve, but it's really a process. It's a way of showing up and building relationships and being with communities and understanding larger contexts and other factors that contribute to health. And so that was a pretty fundamental shift, and those principles have sustained up until today, and were actually reaffirmed in 2018, 40 years after Alma-Ata, saying this is still the vision and what we can and should be working towards. And then also served to, even within sort of a divisive political context, to achieve consensus, and also at least initially a lot of motivation towards focusing more upstream on social determinants of health, larger societal influences on health, and also really trying to get out to the periphery, to underserved populations, and addressing inequities in societies. It also did not have a set of quantitative specific indicators. It did not have a master plan for, how are we going to take this vision, this philosophy, and roll it out. And it also did not have funding attached to it. And so we'll see a little bit later in the presentation what that meant as some of the challenges. But as you'll see on the next slide, the declaration did define primary healthcare very inclusively. And so the red that you see highlighted here covers a bunch of different things, but I do want to pull out 3 common themes that have really been sort of reiterated as the core sort of principles of Alma-Ata. And the first is sort of multisectoral actions. You can see right at the top there, thinking about economic, social, and political characteristics of a country, and considering all the different sectors that need to be involved. The second thing is really maximally involving communities and both empowering them and also really engaging them and ensuring that they're connected with health systems and with other services that they need. And then finally, being able to also think about, equity and how do we really achieve health for everyone, particularly hard to reach populations and subgroups within society, in communities that may need specific care or may have a number of different barriers to effectively sustaining and improving health. Next slide. So this is another way of looking at the same information from the previous slide, more in sort of a visual form. And so these are 7 key principles of primary healthcare that include the multisectoral approach, bottom-up and community engagement, and then getting a bit more into the nuances of, what do we look for more from a public health perspective about, population-level outcomes, what are the epidemiological priorities in a local context, and some of the more functional aspects of how do we engage an appropriate workforce and adapt to the priorities of the communities that we're trying to serve. Next slide. All right, so I'm going to hand over to David to get us started with this set of myths that we want to explore with you and hopefully debunk by the end of the talk. So over to you, David.
Yeah, thanks, Meike. The myths that I'm going to take on are myth 1, that economic growth automatically results in improved population health. Many economists still believe that that's how you make populations healthy, and we'll show that that's just not the case. Myth 2 is that financing universal access to high-quality medical care is the best way to make populations healthy. And that's not equally true. And then the third myth that we'll spend most of today talking about is that the Alma-Ata Declaration was an impractical dream that was never achieved, and cool heads took the day and took us in a different direction. So all of these 3 myths are not true. Let's take on the first myth that says that economic growth is not enough. What you're looking at is the money on the horizontal axis, the log of GDP here. And you're looking at life expectancy going up in the UK from 1800, when life expectancy was 40 years, until 2010, when life expectancy exceeded 80 years. Now, what's happening if you start in 1800, the GDP doubled in the 19th century. Between 1800 and 1870, the GDP really grew, and they were getting a lot richer here, but if you'll notice, their life expectancy did not get above 40. What happened in the 1870s was something new that happened and really started to improve their life expectancy. And we look at the history of the politics of the UK. They opened up universal voting to the blue-collar workers and started to actually invest in sanitation and public health starting in around 1870. So money alone wasn't enough, but money spent on public health and sanitation and in making places healthier is how they turned the corner and bent that curve down in 1870. Myth 2 says that medical care is how you do it. Well, the problem was that from 1870 to here in 1950, there weren't any antibiotics for the major killers of the time. What was killing people between 1870 to 1950 was tuberculosis and diphtheria and measles, and there were not any antibiotics until the 1950s, post-World War II. So something happened here, and the legacy that the UK and similarly in the US, they were noticing these rapid gains in population health without medical care. And so when they turn around to give advice to low-income countries, one would have thought that this would have been the way they marched forward. And Alma-Ata was the announcement that that's how we're going to march forward. We're going to go back to what we were doing during this era. So we've debunked myths 1 and 2. It's not all about having money. You have to use the money to do the right thing. And it's not all about medical care. I'm not opposed to medical care. It certainly does play a role and does help after you've covered the population with public health. But myth 3 is the most insidious. It still is commonly accepted in global health teaching that this Alma-Ata moment was a moment not seized and not taken. It was an impractical dream, never going to happen. And that's not true. And our book shows how several countries show that it was not true. Let me turn it back over to Meike.
Great, thanks, David. So before we start telling you about how different countries have worked very hard to debunk this myth, I'm going to just talk for a minute about where this myth came from. So if you remember, we had the conference in 1978. Everyone was really motivated because of the different case examples that they had to show how different programs around the world were already working towards these issues, and all of the deliberations and effort to bring all the countries together in Alma-Ata and put forward this declaration, and a lot of enthusiasm for, you know, why this was the right thing to do. And then everyone went back home, and then a few months later, a number of different groups, including the World Bank, UNICEF, and USAID, said, well, we really need to think about how we're going to do this, and came together in Bellagio a year later, the next year, and really were concerned because if you look back at the definition, and primary health care is connected to everything. And so it was a bit overwhelming of, you know, how are we going to pay for everything? Where should countries start? Seems really ambitious and just like overload and complex, and we don't really have a plan. And so next slide. There was a publication that's quite well known that came out the following year that put together sort of an alternative approach and said, you know, at least for the interim, at least for the next little bit, you know, here's a suggestion about where we can start. And their focus really was on, you know, let's pick some sort of low-hanging fruit. Let's pick some specific diseases where we know we can make a big impact, and let's make sure we do that. And next slide. That's really where we have spent a lot of focus in the last years. They said, you know, primary health care encompasses all the different segments of the economy. It's universal access to comprehensive curative care. It's so many other things as well. And so, you know, as a place to start, let's do some specific things. And so they focused on vaccinations, on providing oral rehydration, on ensuring that, you know, breastfeeding was taking place. And this became what many of you all may be familiar with, which is the GOBI FFF strategy, which included, you know, these specific interventions that were evidence-based, that were initially mostly about service provision. And then also later the FFF part brought in some aspects of like female education and family planning and things like that, and starting to think about some broader strategies that really involve the community, but coming at it from an angle of, you know, let's solve some of the priority problems, and then we can think about how we build from there. Next slide. So this dynamic that was set up coming out of the strategy has really driven a lot of how a number of major actors and donors in global health have been thinking over the last few decades. And the interesting thing is that, you know, if we look at overall spending for health globally, these three pieces together of high-income countries, low-income countries, and then development assistance as the third bucket, we've got $9 trillion here, the majority of which is going into high-income countries, and then a significant pool, so almost $1 trillion going from being, you know, paid for, health services being paid for within low and middle income countries. And then this final piece that comparatively is quite small, which is the development assistance, that's really been driving the agenda. and has been continually saying, you know, the way that we can show that we're making impact, the way that we can focus our efforts is to continue to invest in these specific vertical programs that deliver services to, you know, groups of people that need them. But it's kept the mentality kind of in that selective way of thinking and planning, rather than stepping back and saying, you know, what is the community capable of doing? How are we able to integrate services together? And what can we build on and sort of leverage that would leverage the resources that are already being generated and used within all countries, and be able to move forward this agenda of primary healthcare. Next slide. Okay, so what we want to show in the next couple of case examples is a couple of the countries that are featured in the book, and showing how these countries have picked up on the vision of primary healthcare and have really made exceptional progress towards achieving the vision of health for all. So we will cover examples from Nepal, Ghana, and Ethiopia, and the rest of the full case examples are also in the book. So if you want to know more about those countries in particular, we're excited that there's a lot more information from some wonderful folks from all of these countries. So these countries have really all focused on, you know, developing the platforms and the relationships and the collaborations and engaging communities and figuring out ways to have that process and that sort of way of being together in order to ultimately, you know, achieve primary healthcare and a lot of progress, but have really kind of put their efforts in terms of long-term development around this vision of primary healthcare. So I'm going to hand over to David first to talk about Nepal.
Great. So we are going to emphasize in our stories how the countries have had to both be and do, and they put together ways to be. And Nepal is really worth celebrating. This is a country that is going to begin its journey with some of the worst health indicators and worst health infrastructure in the world. And the authors for this chapter, Kedar Baral, Nadia Diamond-Smith, and Rita Thapa, spent lots of time working in Nepal. Rita Thapa is one of our alums who received the Distinguished Alumni Award 2 years ago for her contributions to the health of Nepal. So we're going to start back in the 1970s. And in 1975, Nepal, like many countries of that day, had project-based aid. They had projects for malaria, tuberculosis, leprosy, smallpox, etc. And in fact, the Nepal's malaria eradication project consumed half of the national health budget for that one disease. Now, it's an important disease, but our authors noted that that's all you got was spraying and mosquito control, but you didn't have a health system, and you were not addressing any of the other problems with half the budget. So Rita Thapa, our co-author, went to the Alma-Ata Declaration after her graduation and returned to Nepal to lead up some of the health reform in the maternal and child health program. In the 1980s, they started a program called the Integrated Community Health Development Program, which took root to build nuclei, the structures where village health workers would emerge from health posts to scale over and deliver services throughout the country. And they start building this system throughout the 90s, and they keep building it during a civil war. There was a Maoist people's movement that rose up in the 90s and eventually led to the demise of the monarchy. But throughout this time, the revolutionaries would help and assist the village health workers who were implementing this plan. At the end of this story in the chapter, the authors note that primary health care is now consuming more than 60% of the national health budget. It's been a major transition. Let me show you the nuclei that are the building blocks of the Nepali health system. What you'll see here is this hub and spokes model where you have a health post at a large municipality, which reaches out to satellite villages where there are sub-health posts, and the sub-health posts are the home bases for female health community volunteers, FHCV, female health community volunteers. Now, the health post is governed by the municipality. It is also taking some support from the central government, but it is embedded in a process of dialogue and conversation with the people in the municipality, and then reaching out through the spokes to these tinier villages. And when they do their convening, when the municipalities gather together to talk about health, they are talking about health in the context of the other sectors of the economy. And then they have this machinery of female health community volunteers that glue each ward together with social contact, with FaceTime, with being in the homes of everybody in the catchment area. So this is not come to me when you're sick. This is I'm going out to you, and I'm not just taking care of your sickness. I'm seeing health in its context of all of the things that determine it. So if you're at a health post in Nepal, you certainly would have a place where sick people can go to get basic primary care for sore throats and fevers and sick children and antenatal care. There's an outreach center that is the home base for people who are going out and doing home visitation. Importantly, the development committee is here. This is the group that lives in every Nepali municipality that says, what are we going to do for livelihoods and to get better crop yields and to build roads and schools? And they're also linked into the immunization outreach. So this is at the municipality. And then at these satellites, they're going out to these triangles. And let me show you a picture of the triangles. This would be one of those sub-health posts. So out in a Nepali ward, here is your female community health volunteer going door to door, doing maternal and child health, talking all the time with mothers and mothers groups. They're linking through the local development process to the co-ops, to the religious groups, their child clubs, water users groups. So this is not the way a lot of, whoever, there's some medical professionals on the call, where you go to your clinic and wait for sick people to come in. This is not primary healthcare Nepali style. They are going out to do a lot of home visitation and dialogue and talking to the community leaders about what they need to do together to approach health. Here's a picture of some of these FCHVs. There are now over 50,000 Nepali female community health volunteers. They are currently serving on a voluntary basis with minimal, if no, pay most of the time, but they are able to reach everybody in Nepal because there's one FCHV for every 560 people, and their outreach facilities are one for every 2,000 people. And as I said earlier, 60% of the budget is being spent to maintain this type of service, this outreach of women who are connected to their community in constant dialogue with the multiple determinants of health. So hopefully there'll be some more time in Q&A to talk about the Nepali miracle. In Ghana, they also rolled out comprehensive primary health care. And one of the things I wanted to bring up in our Ghanaian chapter, it was led by Jim Phillips, Fred Binka, Koku Awoner-Williams, and Ayaga Bawa, and they were in on it from the start. So we have the firsthand relation of what was going on. And they shared with us this picture of the very genesis moment of the Ghanaian approach. And what you're noticing here is a site visit that the Ghanaians took to Bangladesh. And our Bangladeshi authors contributed a lot to describing what Bangladesh was doing back in the 90s. Well, the Ghanaians went to learn it by going to the ICDDRB field site to learn about community engaged primary health care. And then they went back to try to build on those lessons back in Ghana. So we're going to start in the early 1990s, a similar hub and spoke system to what you saw in Nepal. You have a district hospital, and then following that, you have at a sub-district level, sub-district health centers, and then leading out to what should have been health posts. The problem was in the 1990s in Ghana, these white circles were empty because there was nothing there. There was really no sub-health post service with anything. So if you were needing any type of health services in rural Ghana, you would have to travel a variable distance to get to this sub-district level. There wasn't an army of community health workers going door to door. That wasn't happening. And the Ghanaian team had gone to Bangladesh, came back full of ideas about how to go about bringing this back to Ghana, because that was what the programming from the Alma-Ata Declaration said to do. You've got to have facilities that reach everybody and address the social needs. So what happened was there was a pilot in the district of Navrongo, way up in the north of Ghana, in the most arid part bordering the Sahara Desert. And this pilot in 1994 led to the staffing of these missing pieces, these peripheral community-based health planning and services zones. They wanted to build services there. And so they started with an assessment approach where they got the people in these communities in Navrongo to chime in on how to go about doing it. Very much the architecture and the design came from the people in Navrongo. It wasn't, we've got this blueprint from Bangladesh, we're gonna just graft it onto here. How can we do this was the question that they asked. So the picture that comes from this era of building the Navrongo health system was a work of convening what in Ghana is called a durbar, where the people of the community gather together for a conversation and a powwow to say, what should we do to solve the problem? Now, the topic in the CHPS durbars was, how can we build health services here? What emerges from that is co-financing. These individuals that have gathered at their durbar are excited and saying, look, if we're going to build a sub-health post here, I'm going to help. I've got some land, I've got some bricks, I've got some labor time. So co-financing came and solved the problem that the West said, we're never going to be able to pay for all of this. Well, the people in Navrongo paid for it because it's their health system. Not only did they pay for it, they designed many of the elements in how it would function. So there's co-financing that comes and solves the economic problem. How are we going to get the resources? There's participatory planning going on in a culturally consistent way to how Ghana makes joint decisions. The people in the durbar are developing service needs and strategies. What types of health problems should be treated at the sub-health posts? They are engaged and they are going to stay on board as the project marches forward. This comes in again and again as an important way to go about building PHC. And we were fortunate enough to have an entire chapter on this topic authored by authors Marlo DeRue and her colleagues at the Constellation, who mentioned that this is something that always should happen, that you include the community. They should be included in designing solutions to their problems because they have lived with them. And this was put into practice, and it is now part of the recipe for primary health care in Ghana as it is in many other countries. So as they go forward after the participatory planning phase 1, they have answered the question, what is an appropriate design for solving the problem of reaching the people of Ghana with health systems and health services? They move on to question 2 of how do we get it to work, and does the design work? And they're going to bring in some research element into their phase-in the Ghanaian health system. And then they're going to go on to question 3 and ask, can we replicate it in a brand new place? Were we just lucky as we piloted in Navrongo? Can we do it again? And in question 3, they're going to do it again. And then finally, can we cover the entire country with this? How do we get this PHC to cover the country of Ghana? So I showed you the first phase of getting durbars of Ghanaian citizens to chime in. The plausibility trial really rested on whether, if you built these sub-health posts, that parents would go to them. We've seen around the world governmental designed sub-health posts that are bypassed. So many countries have empty sub-health posts where people say the quality is no good. I'm going to go to the private sector. I'm going to go to the district hospital. Big question in Ghana, will it work? Would parents take their sick children there? Well, because they had the Durbar's input, they designed the health post to replicate the norms of trust of the traditional healers. The people at the Durbar said, well, you definitely want to locate the sub-health post in the village. You'd never want to charge payment. The way we roll, the way we do traditional healing encounters is we'll have deferred payment. You know, we'll get back to you with payment and we'll take care of you when your time comes. So because we had the design elements coming from the people's participation, it turned out that it worked, that parents did go to these local sub-health posts, and they did it instead of the traditional healer. So we're substituting highly effective child health services instead of the traditional healing services that had limited effectiveness, and child mortality started to go down in the Navrongo pilot. Moving on to phase 3, Navrongo is a special place. It's got a lot of resources from the research community, and it's been built up. It's a legitimate question whether Navrongo could work in another setting. So they started in 1998 to replicate it in one new place called Nwkanta. And Nwkanta is a different, highly challenged district in Ghana. And they built this package. Again, before they did the public gatherings, they realized that you've got to know who's on your invitation list. You've got to know the tribal affiliations of who responds to who's in whose kinship network, and they do this as step 1. Then in Nwkanta, they did the step 2 of public gatherings and Durbers to get volunteer commitments, to get capital commitments. And in step 3, they will actually donate and construct the housing and the health post structure. Step 4, you're going to have to go to the Ghanaian government, and they did successfully approach the Ghanaian health system for the examination equipment, for stocking of supplies and medical devices. The nurses needed to be retrained in community organizing. A lot of nursing schools around the world, US included, train you to this: I will wait for a sick person to come into my clinic. And now that doesn't work with PHC. So in Ghana, they had to retrain nurses as community organizers, as people who feel very comfortable talking to the principal of a school or with an agricultural extension agent, with a mother's group about how to create livelihoods. This is a community-based nursing that they required retraining for. So the nurses are put back on track with community nursing. And finally, they bring in, to assist the nurses, this army that you saw in Nepal of community health volunteers who are going to make the rounds and get face time out in the periphery of Ghana. Finally, can they scale it up to the country? Every single time the CHPS builds a new sub-health post or health post, they do the community planning every single time. They also do what many call seed scale, where if you've been successful with CHPS in your district, you're now going to go in and be a trainer in the next district over. So staff exchanges and site visits, come to see how I did it in my place so you can do it in your place. So one pilot at a time. Lucky for them, they engaged the patronage during the presidential campaign of 2008. And the Ghanaian presidential candidate who won that election made primary health care a campaign pillar and said, if you vote for me, I will deliver primary healthcare services out in your sub-health posts. So when he's elected in 2008, he then says, the money for this isn't going to come from donor funding. I'm not going to raid, HIV money for this. I am going to put up a new payroll tax in the Ghanaian tax base to fund primary health care. Again, solving that big worry that the West had of we have to pay for everything. Well, by paying for vertical programs, they were actually stalling this transition to primary health care. And with the patronage of the Ghanaian president, the Ghanaian health system built the funding base that helped to scale this up. And so now CHPS and primary healthcare covers 85% of the Ghanaian population, funded by Ghanaian resources that it's getting out of its tax base. So let's turn it over to Ethiopia and see how this echoes the themes that we've built up so far in our talk. Go ahead, Meike.
Thank you, David. So yes, last case study for today is looking at Ethiopia. So what worked there? Next slide, there is a brief timeline here. So in the 1960s and 70s, there was very low access to basic services, particularly in rural areas in Ethiopia. Could have been 20% or less of the country had access to sort of any kind of curative services or up-to-date, accurate information about health issues. And so there was a period of time around then and into the 1980s when there was civil war and there was a lot of political turmoil, including the Derg regime, and services certainly didn't improve during that time. And then in the 1990s, there was a transitional government that was put into place that started this rebuilding process and really sort of refocused on, how are we going to develop the country and what should our priorities be? And in 1997, the first health sector development plan was put together that wasn't terribly groundbreaking, but it was their first sort of plan. And during that time, there were pilot efforts, particularly in the Tigray region, to establish a community health worker cadre and figure out how basic services could be more directly implemented at the community level. And so that led to the founding of the Health Extension Program initially in 2003, which was focused on agrarian populations in rural Ethiopia with these health extension workers, which we'll talk about more in a moment. And that was able to be scaled up to much of rural Ethiopia. In 2007, they adapted and further expanded that program to be accessible and sort of workable for pastoral regions. So, groups of populations that are moving with their animals and need to be able to be accessed, wherever they happen to be. And then in 2009, the Health Extension Program also expanded and further adapted specifically for urban areas. So certainly Addis Ababa, the capital city, and also some other larger urban centers. And then finally in 2011, the Women Development Army was added to the Health Extension Program, and we'll see in a couple of slides the reason for that and what that also added to the program. So that's a bit of an overview. As you can see, it's been really the last almost 20 years that the efforts have really been consistent and have resulted in a national program that's reaching the majority of the Ethiopian population at this point. So next slide. The so the Health Extension Program fits into the health system in Ethiopia in a really fundamental way. So if we start at the top, you'll see, like, as you would expect, specialized hospitals, tertiary level care, moving down sort of the general hospitals, secondary care options that obviously you would find in larger urban centers. And then as you get to that sort of most developed tier there, you have the primary health care level of the system. So that does include primary hospitals, but also includes health centers, which are sort of basic level clinics that are able to provide much basic care that communities might need. And then finally, a health post level, which provides also a lot of services, including immunizations and health education and things like that. And you can see that for the rural populations, this is broken out more, and in the urban populations, because groups of people are living much closer to each other, and also access to health services happens a bit differently in urban populations, that primary healthcare level of the health system is sort of consolidated. So if we move on to the next animation of this slide, I think that we will see that, at that primary healthcare level, we have the primary healthcare unit, which includes the health center and the health post, which are the facility-based aspects that are connected with sort of the district or Wareda level health office, which does administration services and works, handling health information and things like that. And then within that red circle, we have sort of the key aspects of the health extension program that take it beyond the health facility as well. So we have the health development team, which reaches 20 to 30 families and connects to the sort of smallest level administration at the Kabele level. And feeding into that health development team, we have neighborhood level 1 to 5 networks, which include 6 families. One of them is a household that has achieved the model household status. So this is a key set of sort of health behaviors and a status that the household works towards with the help of the local health workers and collaboration with neighbors, and then obviously at the very fundamental level, the households themselves. And so where the health extension workers, which we'll talk more about in a moment, kind of fit in, is that they are this sort of linkage between the health post and communities. And so they're almost always from the communities that they serve, and they work part of their time in the health post and part of the time out in communities, doing very similar kinds of things to what David has described happening in Ghana and Nepal as well, in terms of health education, getting to know the community, identifying pregnant women, making sure that families are getting the services that they need, and then also being at the health post to provide basic medications and receive people who do need further care, and are also able to refer up to the health center to additional providers as needed. So next slide. So the health extension workers are this cadre of workers that was added in Ethiopia that's really aiming to bridge between the health posts and communities. And these are professional workers. They're trained for a year. They cover about 500 households each. They are, there are about over 40,000 of them now, of which about 4,000 are the urban health extension workers, and the rest are working in agrarian and pastoral populations. And they're serving about 90 million Ethiopians. So this is a national program that has adapted some over the years. They started out with a core set of services focused on maternal and child health, water and sanitation, health education, nutrition, things like that. And more recently have also added services around mental health and non-communicable diseases as sort of the epidemiological transition is happening as well. And so these workers are a key part of the Ethiopian health system. They are paid for primarily by the government funds as well. The government of Ethiopia has had really strong support of this program, particularly when it was first founded. The Prime Minister was a great champion of it, and they've been able to coordinate a number of development partners to kind of feed into this vision in sort of a one budget, one plan, one report kind of strategy, where the government says, this is our health extension program, this is what we need to pay for, and then having development partners sort of feed into that and say, well, we're willing to pay for this piece and we'd like to support this aspect, and being able to sort of piece the puzzle together that way. And then the government also contributes funding to make this all happen. Next slide. So I mentioned earlier that one of the final, most recent major changes and additions to the health extension program has been this addition of the Women Development Army. So the health extension workers are these, professional salaried workers at the community level. They're doing incredible work. But that Ethiopia also realized that if they really wanted to be able to effectively engage communities, do that multisectoral work, and be able to ensure that they're reaching all of the families that need services, that they needed like one more layer of connection to those communities. And so the Women Development Army are these women who are part of the 1 to 5 networks that have achieved the model household status. And then they convene and work closely with their neighbors in order to talk about health issues, but also nutrition issues, water and sanitation issues, how their agriculture work is going, other concerns that they have, thinking about, how to save money together, and whatever other concerns that they have. And the health extension workers provide supervision and support to these Women Development Army volunteers. So there are about 3 million of these women across Ethiopia. And they are really kind of the community-based movement for primary health care in Ethiopia, and really ensure that the health extension workers understand the concerns of the community, and that communities are part of making behavior changes and understanding how they can solve the problems that are priorities for them. Next slide. And this is a photo of the health extension worker is the woman facing sort of directly away from us in this photo with sort of the pink skirt. She's a health extension worker, and this is one of the groups of Women Development Army volunteers in their neighborhood in the Tigray region of Ethiopia. So this is how they come together. They maybe at someone's home. I think this was a photo in the yard of one of the women, and they're able to, you know, sit together, talk about what their concerns are, support each other, help problem solve, and really have that strong relationship with each other, and also a channel of communication through the health extension worker to bring their concerns and their questions to the rest of the health system as well. Next slide. And I think, yeah, so just to make the transition from Ethiopia into the final part of our talk, which we're wrapping up in the next few minutes, is just to show that, you know, the health extension workers in Ethiopia have been a critical part of the COVID-19 response. So particularly the urban health extension workers in Addis Ababa have done an incredible amount of work with screening and counseling and helping with behavior change issues, and just really being part of that sort of frontline response to COVID-19. And next slide. They've also been a key part of really generating and sustaining trust with communities, and being able to sort of keep a finger on the pulse of what's happening in Ethiopia as the COVID-19 response rolls out. So back over to you, David.
Hey, thanks. So I do want to wrap up quickly, and so please forgive my speed right now. I want to just wrap up with what have we learned from these 3 case studies. Well, one icon here is the WHO operational framework. They have been tasked through a World Health Assembly resolution to help assist countries with scale up and implementation of primary health care. Their framework brings up what our book is bringing up, that the ingredients of primary health care are empowered people and communities, the Durbers that you saw, the Development Army. You'll see that they're multisectoral here. They are engaged with the process of development in a community, and they improve both primary care, taking care of sick people, but they have to do public health. The thing that helped create this major improvement in health in the West is now part of what PHC is doing in the Global South. Development means being a place that can cope with new challenges and set out and achieving its goals. So COVID-19 is incredibly complex. It has to be handled by something with this level of complexity. And PHC is the way forward for this. The assets that we saw building were communities that trust their health system. Imagine having that everywhere to help cope with COVID-19. But it was multisectoral. This wasn't just health workers, the health workers in charge with commerce and business and schools and agriculture. And the way that the community said, this is how you can reach us. This is how you can build health equity. So these assets get mobilized. The hubs and spokes goes out and reaches through the assets, because the community health workers are going door to door, literally gluing, well, not literally, but figuratively gluing a community together with social connection. The lessons. There is no opposition to what PHC was doing and the West's focus on the delivery of selective interventions like vaccines and vitamin A. The donors' focus, though, on just do was irrelevant to, and it could actually hinder these transformations in how we did health. These checklists of do are now giving way to new checklists of how to be a place that does primary health care. The WHO, in building its operational framework, has now given us a checklist of the things that would differentiate a highly effective primary health care program. So if we have a checklist like that, we have to stay mindful of the checklist. Our high achievers asked for community help to set up these structures, but they stayed on point, and they kept on saying, how can we do it better? So in closing, what we're finding as a lesson for the future is to mind this, not just set up a checklist and say, we got a checklist. To keep that checklist coming back, take repeated measures of how are we doing in primary health care, think about how to do it better, and put in a process of quality improvement, the way you would do in any modern hospital. The quality improvement team is there to use checklists to make it better. It's not just a matter of do this checklist. There's no magic to it. So comprehensive primary health care unites primary medical and public health practice. it engages non-health actors, it is automatically going to be the convener of solutions to COVID-19. Now, it's crowded out, it's invisible, there's glamour and money in taking care of sick people, but that's really, there's no other choice for sustained development in health than to build these structures. Now, we see that success was deliberate. There was a focus on integration, one village, one district at a time, with this on the ground process of gluing the community together. So I'll stop now and we can turn to questions. I think both Mike and I can see your questions. And I'll turn over the first question to Meike. Karen's question is, why do we say comprehensive when we talk about comprehensive primary health care? Meike?
Yeah, so I would say that, you know, there's been this confusion between primary healthcare and primary care, primary healthcare being what we've been talking about for the last hour and primary care being, you know, basic clinical services. And so I think we often, David and I often, and many others who are working in the field, really try to emphasize, we're talking about comprehensive primary health care as this vision from Alma-Ata, in order to be very clear that it's not the selective primary health care that came out of the Bellagio conference and the Walsh and Warren you know, efforts, and it's not primary care. And so I think we're just trying to be exceptionally clear so that we don't get it, doesn't get lost sort of in all of the variations that have sort of taken on their own meanings over the years. So would you add anything to that, David?
No, perfect. Thank you. Let's move on to question 2 from R. Shah. It says that many of the concerns of donors persist, and there really is a lot of business as usual carving up of global health. I will note to you, Mr. Shah or Ms. Shah, that that's still what we see in the West is our focus on the foreign aid budget, which is only $50 billion out of a larger budget of countries' own money being spent in PHC. And what our book found is that the country's own money being spent in PHC is increasingly oriented towards PHC. But in the donor space, which is again a small sliver of money spent on health, I'm excited to see very friendly places now. I think that Bill Gates gets this. He talks about it, he reads about it, and he has put some of Gates's resources around the PHC Performance Initiative to give us checklists. So there is some support, but again, we shouldn't be all full of Western donors as the saviors. What we found in our book was that the countries and places around these places that need PHC have been the prime movers of putting these systems in place. And we should probably just step back and help them and get out of their way and saying, stop doing your PHC and deliver my bed nets. That would be counterfactual and harmful. Let's move on to Aaron's question. Aaron says, do we believe that CHW programs that rely on female volunteerism are actually a setback for women? What do you think, Meike?
Yeah, thanks, Aaron. I think that's a great question. And I think this is one of the reasons why we're seeing a lot of the current dialogue, appropriately so, around community health workers saying, you know, these are essential workers, they're professional workers, their work is incredibly valuable, if not invaluable. And so, you know, they should be compensated, they should be, you know, valued both monetarily and then also often non-monetarily as well, but that the financial compensation is really important. I think it does depend quite a lot on sort of, you know, what you're expecting from community health workers. And I think we still don't have, and maybe it's fine, but we don't have a very sort of consistent definition. I mean, it could be anything from, you know, a volunteer that doesn't require a lot of training and really, you know, does most of her work as kind of part of her daily life of interacting with her neighbors and you know, taking care of her family, to someone who's actually working, you know, full-time, providing a lot of curative services, needing to travel and be in a health facility and everything like that. And I think the kind of remuneration and the amount and all of that needs to be just sort of appropriate given what those workers are being asked to do. But I do think it is absolutely essential that the work of community health workers gets compensated fairly, and ideally both contribute contributes to financial resources that women have, and also to sort of elevating their sort of social value and position and opportunities within the society. So that's what I would say.
Thanks. It's
Anything
an
you want to add
important
to that,
topic.
David? Yeah.
Uh,
There's some fantastic literature really sort of showing what some of the issues are with the volunteerism of community health workers as well. So I'm happy to share those if that would be of interest to anyone.
Yeah, Paulina, your question about China, has China moved away from PhD, is sadly yes. And what worries me the most is that China is now a new big player in global health, and it has a lot to teach, and yet it's not seeing that lessons from its own past of the barefoot doctor. So if you're listening, China, please wake up to your greatness and use that as you give advice to the countries in Africa where you're active in global health. Moving on, do we need new skills and a new workforce staff? What do you, Meike?
Since we're about out of time, I would love to tackle the last question, which is from
let's do
Dawn,
that,
which is
and then
how
we're going to
can
run out
these
of time.
models be used in the third world areas of developed countries? So I actually grew up in West Virginia, which is one of the poorest states in the United States. And as I'm sure we're all aware, the United States is really struggling with COVID and also just with public health in general. And so I think what I've seen in working with community health workers in West Virginia also is that a lot of these models really can be translated. There's even more complexity here in the United States. There's even more money at stake. So I think the challenges are, if anything, greater, but I think that we do face a lot of the same sort of fundamental disconnects and issues that primary healthcare does help to solve. And I think there are also a number of really fantastic examples of work that include community health workers, but also all of these other aspects of, really engaging communities and working across sectors to improve health status and ensure that we reach everyone here in the United States as well. So absolutely.
Great. Thanks for the great questions. I know we're out of time, but it's been lovely being with you, and we look forward to engaging with you at another time. These slides will be put up and the talk will be recorded for future use. So I want to thank everybody for coming, and everybody stay safe and be healthy.
Thanks, everyone.